All right, everybody, this is Dr. Kachikian with the Black Hills Regional Eye Institute, and today I wanted to show you a case of a small pupil white cataract that I did. First, we injected some omidria, trying to dilate that pupil a little bit more. Then we'll put a little bit of lidocaine in. And I just thought I'd show this case. It might be a little bit controversial in terms of how you might want to approach it. But you'll see what I did, and you can kind of compare what you might do. Put some viscoelastic in there, and then we're going to put some trypan blue. I tend to put the trypan blue, in this case, under the viscoelastic. And this is a small pupil. I'm not going to use any iris retractors. At least my plan is not to. And so we're going to make our incision. We're not going to use any iris retractors. We have to make sure this incision is not too short. It has to be a good length. And one way to do that is to start a little further up on the cornea. You can start kind of in the clear cornea as opposed to at the limbus to try and get a better length. And then I use a single bevel blade, and so you just want to make sure that bevel or that blade doesn't enter the cornea too early. You want a nice long incision. So we put some dilating solution in there with the omidria. We've got our viscoelastic in. Now we're going to use our trypan blue, and most commonly I will paint the trypan blue onto the surface of the lens. I feel it gives a deeper stain. Sometimes it's a little bit patchy, but I can just kind of brush the trypan blue onto the surface, and so you'll see what that looks like here in just a second. I didn't want to edit this. I just thought I'd show you how long it took me to do this particular case with small pupil and a white cataract, so I didn't do any editing. So here I'm just waiting for the trypan blue, and we'll paint that on, we'll rinse it out, we'll place more viscoelastic, and then we'll do our capsulorhexis. My guess is that we just didn't have the trypan blue ready. Here we go. So put that on there, and like I said, I'll paint that on to the surface here. Now we don't really know, it can be hard to tell, I find it hard to tell, how much liquid cortex there is in these lenses. Because remember, the liquid cortex can be located posteriorly in the posterior lens, still causing pressure. The other thing to know, when there is liquefied cortex, it's loculated, so there can be little pockets. So you might find that you start off your capsulorhexis pretty well, but then you get to this pocket of cortex that expands out in a certain area, and that causes your rhexis to kind of extend to the periphery a little bit. Maybe not out all the way, but the pockets of cortex have some pressure associated with them, and when you get to them as you're doing your rhexis, the rhexis can extend out. So what I usually do in white cataracts is I enter with a 27 gauge needle on aspiration to try and aspirate any liquid cortex that might be present, and then I will extend the capsulorhexis with the needle. So not very much liquid cortex here. We'll see if there is any as we continue the case. And so we'll grasp, and then we're going to have to make our capsulorhexis as large or larger than the pupil edge. And so it's helpful. You don't always need to see exactly where the rhexis edge is, as long as you can see that capsulorhexis and you can see your leaflet that's folded over. Kind of take our time going around here. And this capsulorhexis is slightly larger than the lens. I do find that in small pupil cases, it's sometimes harder to get the capsulorhexis larger than the pupil. So in small pupil cases, often you have smaller capsulorhexis. You have to do some work to try and get that capsulorhexis out past the pupil. Now we'll do our hydrodissection. And you can see that this particular iris, isn't terribly floppy at the moment. It's small, but it's not floppy. That's something else I tend to do at the beginning of the case in a small pupil case, is I'll irrigate some BSS into the eye and see how the iris reacts. If it's a small pupil case and the pupil doesn't move, then the iris isn't very floppy, but other times just the irrigation of BSS can cause the iris to kind of wave in the stream of the BSS, and you've got a floppy iris. So we've got some more viscoelastic in there, get the pupil as large as possible, and now we're going to come in, we're going to buzz in quadrant mode and try and get just kind of a little central tranche that we can purchase into and chop, because this is a white cataract, we can chop it. We're going to go out under our capsular rexus and complete our chops here. Again, you can see that pupil isn't moving. So while it's a small pupil case, I wouldn't necessarily call this too much of a floppy iris. You do have to be careful if you do a small pupil case and the iris is floppy. You can more easily aspirate the iris into the tip of the phaco. One thing you do want to try and do is just get the pieces up out of the capsular bag, and when you do your phacoemulsification, do it more in the anterior chamber. I usually tend to use the chopper right in front of the phaco handpiece to prevent any iris from being aspirated. So almost always that chopper will be ahead of and slightly across the phaco tip. And that is to prevent any iris from being aspirated. We'll kind of get our last few pieces and rotate the lens and chop again. The other thing, more viscoelastic. In these cases, because you are phacoing more anteriorly, you are going to want to put in viscoelastic more frequently. Fortunately, although this is a white cataract, it isn't terribly dense. The white nature just makes visibility somewhat poor, but the density of the cataract is reasonable. The other thing that tends to be nice in some of these cases is there's not a lot of epinucleus. We get a little more visco in there, but in white cataracts, the cortex can be kind of adherent. And there's the edge of our capsular rexus. We want to be careful there. Pull this piece out. Nice. Keep the second instrument right in front. There we go. All right, we'll get out this last few. That's like an epinuclear piece. And now it looks like we've gotten a lot of cortex out, but it's hard to tell because you can't see the edge of the capsular rexus. And so I don't remember what I do here. I probably use some BSS to try and irrigate. We'll get our last piece of cataract maybe in the periphery there. Let's get those air bubbles out of there. Perfect. And let's see. Sometimes you can kind of blindly sweep and see what sort of cortex comes out. Other times I'll use a stream of BSS to see what gets freed up and what gets liberated. Where is the cortex? There's a little bit there. There's not a lot. We'll go through the main incision and maybe do that same thing. No, just take our handpiece and try and get out any bits. And nothing wants to come. So whatever I sprayed off there just decided to stick into the periphery. Irrigate here, you've got some PSC kind of cortical combination pieces there. We'll see if we can liberate those with some BSS. That's not bad. There's some cortex. So let's go in with that second instrument. And the other thing I find helpful in these situations, let's go with the IA. The other thing I find helpful in these situations is to use the second instrument. Now in this case, it would have been more helpful at this point at least to have, and the patient's moving quite a bit, to have some sort of iris retraction. So instead, we will use our second instrument to try and look and see how much cortical material is remaining. There's a bunch right over there. So let's try and get that out. And some subincisional here. And do a little bit of polishing there. We'll kind of work our way around. A little hard to see in the view here, but this is where I think it's debatable. You know, I thought there'd be less iris trauma. And usually it is the case there's somewhat less iris trauma when you don't necessarily use an iris retraction device. At the same time, you don't want to leave any residual cortical material in the capsular bag. There's some there. Let's see if we can get to this. It's extra hard because not only is it under the iris, but it's also subincisional. And as you can see, that IA just wants to aspirate the pupillary margin. So we'll go back in with a little bit of BSS, see if we can free it up. I do find irrigating with BSS to be extremely helpful. There we go, to liberate any sort of retained cortical material, to clean out the fornix if you think there might be any cortical material there. So we'll go back in with our IA, see what we can get out. But after this, I think that's probably going to be about it. Now, let's see if we go in with our Provisc, inflate the capsular bag as much as we can. That's a reasonable size pupil. You can kind of see the pupillary margin there. And then we'll get our lens in. And in these cases, in this particular case, I am using a B&L Li61AL, so silicone lens. Now here you do have to be careful because you want to get those haptics in the bag, and with a small pupil, that can be difficult with a 3-piece lens. The leading haptic is obviously not the hard part, although you do want to visualize it going under that distal capsulorhexis edge there. And it's a silicone lens, so it comes out maybe a little quicker than you want. That was pretty good. And then we'll see if we deliver this into the bag, or maybe deliver it right into the bag. Perfect. That looks like it went really well. But we'll check it out. We'll use our second instrument, our Arsinski hook, to identify exactly where the edge is. A little out of focus. Just checking there to make sure that lens is in the bag. Now we'll get our IA going. Try and get back on the screen here. There we go. Just try to visualize where the haptic is. And again, you're kind of, there's a little trauma to the iris here, of course. Is it more or less than it would be if you had hooks or a ring? Maybe, maybe not. Again, that's for you to decide and kind of debate. I will tell you, on day one, this patient looked really excellent, and I did not feel like not using any sort of iris retraction device was detrimental in any way. Get out all of our Provisc. Do try and get behind the lens again, something that's a little harder to do in a small pupil case especially. I find it harder with a silicone lens and with a 3-piece lens. But you can see that fold in the posterior capsule there, so you know you've gotten all the viscoelastic out behind the lens, or at least the majority of it. Seal our incisions, inflate the sides and the top. Was kind of checking to make sure that that visible haptic was still in the bag. And after checking a couple times, I'm fairly certain that it is. The other thing that helps to identify where the haptic is that crease. You're less likely to have that posterior capsular central crease if the lens is not in the bag. But yep, there it is. You can kind of just see right there. But I do want to check that because seeing the edge of that optic / haptic there made me wonder if that was in the bag. That would, however, have been the anterior leading haptic, and so the likelihood that that's not in the bag is pretty small because we directly visualized it. All right, lens is in place. Looks real good. Check our incisions. We'll give a little injection of Kenalog as we do at the end of the case, and that's it. All right, I hope you folks enjoyed this case. I thought it was a good one given the small pupil. I do use iris retraction devices, especially when the iris is floppy, but less likely so if the iris seems stable. Have a great day.